everybody. Welcome to the VIA webinar. My name is Graham McCourt. I'm going to apologise to everybody for a start about my voice. I've had some illness recently and I'm just working my way through it, so if I lose it occasionally, please bear with me. We're very fortunate today to have who I believe the expert in synchronization and work of breathing and ventilation. He's an old friend of mine. We've known each other like 30 years. We've worked together before. His name is Dr.Lluis Blanch. He's from Barcelona. When we talk about Synchrony, there's only one name that I can think about. And Lluis, I think that's a very good, glowing reputation for you to live up to today. I think your webinar will be excellent because breathing on ventilators is never easy. And for some reason, people don't think about it. Lluis, welcome to our event. It's a great honor to have you here. Maybe I can ask you to introduce yourself a bit more about your interest in ventilation and engage us in this wonderful topic of synchrony. What's wrong with it? Thank you, Lluis.
Okay, thank you, Grim, for this nice invitation to be here for this webinar. I am Lluis Blanch. I am a senior intensivist at Parc Taulí University Hospital here in Spain. I am also research and innovation director in my institution. One of my favorite topics is the patient-ventilator interaction, and in fact, in the last years, I've been working not only to collect waveforms using connectivity platforms, but also to apply software in order to find, answers on the different ways the patient interact with the ventilators. And today, I would like to speak about not just to define asynchronous, but to be a little bit controversial about asynchronous and patients under mechanical ventilation, and trying to stimulate you, to think on physiology when you are, in that case, at the bedside. So I'm going to share the screen, please. Right. Okay. So, okay, that's my talk, ventilator synchrony issues, and my, oops, I cannot move back and forward. Maybe because I am in the, let me do something. I'm going to share. Okay. I think this is the good one. So I'm getting expert on that Zooms and so. So first of all, this is my conflict of interest. I am inventor of 2 patents. Both are related with systems to monitor mechanically ventilated patients. I am also founder of a spin-off participated by my institution, which deals with connectivity and artificial intelligence applied to physiologic signals. I would like, first of all, to start with some physiologic principles. And when we are looking at a patient under mechanical ventilation, we should think that there are 2 organs that they are interconnected. And these 2 organs are the lungs, in that case, and the brain and the respiratory muscles. Why that? Because there is a huge crosstalk between brain and lung when a patient is critically ill, patient under mechanical ventilation in the ICU. There are some common, as you will see here, injurious predisposing factors which are related to the disease. But then there are some specific from the brain to the lung related when there is severe injury, in that case, to the brain, because in that case, the lung is predisposed to get more injury by the inflammatory effects and the catecholamine release from the brain, but also from lung to the brain, because there are factors related with hypoxemia, hypocapnia, impaired respiratory mechanics, and also dyspnea or asynchronous, or simply ventilator-induced lung injury. In more extensive review, with all these colleagues here, we just pointed what are the connections between the brain and the lung. And the connections are related. I mean, if there is brain injury, there is, in that case, it can be affected the respiratory pattern, and this may cause asynchronies, and also the important sympathetic and parasympathetic activation, in one case for vascular tone, and in the other way to modulate, to regulate, in that case, inflammation. But from the lung, in that case, I mean, to the brain, there are also factors related with gas exchange, with the biotrauma produced by the disease, plus the effect of the mechanical ventilator, which is overstretching. And in that case, there are a number of effects in the brain, mostly one of them important is apoptosis, but also effects in the respiratory drive. When the patient increases or decreases the respiratory drive, this condition how they interact with the mechanical ventilator. Talking about the patient-ventilator interaction, I would like, in that case, to review, I mean, the factors that affect, as you will see here, I mean, factors that affect the respiratory drive. And these are anxiety, pain, discomfort, inflammation. Now there are new discoveries, like the effect of the new virus SARS-CoV-2, because it has neurotropism, in that case, not only to the respiratory center, but to some cortical areas here, the biochemical input, acidosis, delta space, and CHAN, and also the mechanical input. The consequences of high respiratory drive are well known. I would like just to review for this talk are lung injury, because it causes alveolar damage, microthrombosis, capillary leak, lung edema, impaired gas exchange, and impaired mechanics. This causes increase in transvascular and in transpulmonary pressures, because there is a decrease in the alveolar pressure, because there is an amplified esophageal swing, increase in tidal volume, pendulum, esophageal swings, I said before, an increase in rate. That's why this term, patient self-inflicting lung injury, has been coined by several investigators. But I mean, using that term is a little bit controversial, because the patient don't want to inflict injury to the lungs. It's simply the consequences, because the patient cannot breathe in any other form. That's why it may increase lung injury. This is the classical picture of the Tobin book. I mean, this patient presents a profound desynchrony between the patient and the ventilator. Looking here, we see a patient with an open eyes. The patient has nasal flaring, is sweating. It uses all the respiratory muscles to inspire and to expire. There is tachypnea, and also there is a hemodynamic impairment, in that case, tachycardia. I mean, all of us, believe that if we are at the bedside, we see that, this patient has a profound poor patient-ventilator interaction, and we must do something. And the first thing is understand the physiology behind this, what happens in this type of wrong patient-ventilator interaction. This can cause dyspnea, discomfort, delirium, anxiety, lung injury, muscle injury, and it may increase mortality. The classical definition in that case of asynchronies are those that appear during inspiration, in the transition from inspiration to expiration, or those that appear during expiration. All these can be found in these recent reviews by different groups. However, we can have another classification, perhaps much more interested at the bedside. The asynchronies, that they are caused by insufficient assistance, usually because there is a high respiratory drive, and assistance, from the ventilator is not enough, and the others that they are produced by an over assistance, usually because there is a low respiratory drive. If we took the first one, in that case, the high respiratory drive for insufficient assistance, we must review, in that case, the flow desynchrony. This is the classical picture of Marini saying, showing that in a completely passive breath in a patient under mechanical ventilator, if the patient is not doing any inspiratory effort, all the work is done by the ventilator. However, if the patient starts to breathe, and this is the swing in that case in the esophageal, the pleural swing, and this is the surrogate of the esophageal pressure, then the work is divided by the work done by the patient and the work done by the machine. If the patient increases the drive and increases the swing, the work done by the patient will increase up to a point where the work done by the machine will be minimal. And this is a very important condition at the bedside that needs to be analyzed because it can produce different asynchronies. This is an example. It's the same patient in these two slides. Not only the next one. This is a patient that, I mean, it triggers the ventilator and is very well adapted to the ventilator. This is volume control, a square flow, and you can appreciate here that the flow is below 40 liters per minute, which clearly is not sufficient, I mean, in that case, to fulfill the needs of the patient. When this patient starts to have flow desynchrony, it increases, in that case, the air hunger because the flow is not enough. Then, I mean, it's start doing, increasing the work of breathing up to a point where all the work is done by the patient. When the inspiratory time is prolonged more than the ventilator inspiratory time, then appears the breath stacking. So it's double trigger plus breath stacking. In that condition, there is consequences because there is a stress, because the pressure in that case increases because there is double tidal volume within the lungs. And you can see here that if we have decided that we want to apply protective ventilation, this is the tidal volume doubles. I mean, this is the automatic reset of the ventilator to avoid the drift. This is not an expiration. We must recognize this in the ventilator screens. When that happens, in that case, the double cycling path plus breath stacking, there is an increase in a strain, an increase in a stress. This is a work that we did. We collected all waveforms throughout all the mechanical ventilation period in 67 patients, almost 10 million breaths. And we found here that this is double cycling and breath stacking breath. You will see how the tidal volume in all the three modes of mechanical ventilation, it almost doubles. In that condition, it produces a strain and it produces a stress. But interestingly, in this research, we found that, I mean, the double cycling and breath stacking occur only in 0.6% of the breaths during the total time of mechanical ventilation. Then, I mean, we can thought, and we will be wrong, that maybe this is not injuries. But then we discover that things happen in a different way. I mean, this is a cluster. So these are groups of double cycling and breath stacking that happens in a certain period of time. This is 2 minutes of a cluster of 26 minutes. And then we also discover, and I will comment, I mean, along the talk, that a patient perhaps can present these clusters during one night or at the beginning of the mechanical ventilation period, and then this will disappear for the next days. That's why the important thing is not if the patients are doing occasionally some asynchronies, but how these asynchronies happen. In fact, you can recognize here in this airflow, airway, and tidal volume tracing a profound, I mean, poor patient-ventilator interaction. When we examine in a certain period of time, in 7 hours, this is a night period, it can be found that there is more than 3,000 ineffective efforts and more than 1,000 double trigger. If this happens in the 7 hours and then disappears, maybe this is enough to increase lung injury and maybe, I mean, will affect outcome. There is a lot of research on that. So let's move to another important asynchrony, which is the reverse triggering. Reverse triggering was discovered by Rich Khaled, I mean, in 2006, then was really characterized by the group of Brochard and Akumianaki in chest in 2013. And we worked with the group of Laurent Brochard trying to find an automatic algorithm to diagnose reverse triggering. What's reverse triggering? Reverse triggering is an asynchrony that is produced when there is a breath which is completely time cycled by the ventilator, and this, I mean, inspiration stimulates a contraction, in that case, of the respiratory muscles. According to the, and this contraction could be as high as 14 centimeters of water, so the amplitude of the pressure swing could be as high as 14, or could be as low as 4 centimeters water. That's why clearly you will recognize that maybe this asynchrony, I mean, is not, it will not cause injury because it may condition the respiratory muscles. This may be the case that the patient, I mean, is regaining muscle activity, I mean, because sedation is decreasing, whereas this asynchrony clearly can cause, in that case, increase in stress and in a strain, because there is, in that case, breath stacking. When we examine in that paper using this automatic algorithm, we measure all the cycles, the amplitude of the muscular pressure, all the breath, which is reverse triggering plus breath stacking, the amplitude of the pressure swing was high compared with reverse triggering without breath stacking, the synchronous breath, this is a pressure support, or when there was an ineffective effort. This is data in 17 patients showing that reverse triggering with breath stacking always is associated with high amplitude of muscular pressure. And look at in this particular patient, this is particularly injurious. This not happen when there is reverse triggering without breath stacking and during pressure support, where you will see that, I mean, it's perhaps is a little bit high, the PIMUS, but not reaching these high levels. Therefore, I mean, all the asynchronies, when happen, they should be weighted, they should be calibrated according of the consequences of this asynchrony in the patient. So we need to think always, in that case, in physiology. These are just two examples on what we can do. I mean, reverse triggering can cause entrainment. And when there is entrainment, usually, I mean, as a frequency 1 to 1 or 1 to 2, this is clearly 1 to 1, it can origin, I mean, this particular breathing pattern. This is esophageal pressure, airway pressure, and also a time cycle ventilator breath, I mean, triggers, I mean, a respiratory effort of the patient. So, and this is continue. This is caused it seems, by high spinal reflexes. In that particular case, we need to think on physiology because these authors decrease the respiratory rate, and immediately decreasing the rate, I mean, each breath, each inspiratory effort of the patient was followed by a ventilator breath. So the patient triggered the ventilator and the reverse triggering was abolished. This is another one, an entrainment pattern. Here is causing, as you will see, breath stacking. And look at the esophageal swing, amplitude is higher here. In the same case, decreasing the respiratory rate, and immediately, I mean, the effort of the patient disappeared, and from time to time, a reverse triggering, appearance. So we need to think in that case in physiology to match the respiratory rate of the patient in order to trigger the ventilator, in order to reverse trigger, or maybe increase a little bit the tidal volume. So we must be at the bedside, I mean, to look at, I mean, to diagnose, to understand those asynchronous, and then act in consequence. So another tracing, I mean, this is another tracing in a patient where we collected, in that case, all the signals, and we apply algorithms to automatically diagnose breath stacking and reverse triggering. Again, this is a profound poor patient ventilator interaction in the form of, breath stacking, reverse triggering. This is reverse triggering, but not causing breath stacking. And this is produced in all breath. This is 1-to-1, but in some of them there is breath stacking, and in some of them there is no breath stacking. In 12 hours, this patient presented almost 2,000 breath stacking and reverse triggering, almost 6,000 reverse triggering. This is a huge cluster. This happens in 12 hours, and maybe that's all during all the course of mechanical ventilation. Then we need to think on, in terms of, are asynchronies important? Yes, because it is not when they happen, but how they appear during the course of mechanical ventilation. Asynchronous breath stacking and these huge, swings of pleural pressure can increase a different regional ventilation, as you will see here, a different, in that case, a different region over, a stress, as you will see here, and also pendulum from the non-dependent to the dependent areas. All these together can increase lung injury. And this is perfectly shown in this paper from the group of Yoshida and Marcelo Amato, that they measure local lung stretch in the dependent areas by impedance tomography. And this is a reverse triggering breath, very well characterized by the esophageal pressure, is time cycle ventilator breath. And in the middle, this inspiration causes this inspiratory muscle contraction, which increases the lung stretch in the dependent areas, probably by a phenomena in that case of pendulum. So when that happens, if it happens, in certain amount, they can cause injury. When we look at the asynchronies, we need always, to translate to the vascular side. The vascular side of the lung is very important because it may have terrible consequences in certain circumstances. This is a mechanical breath, and this is a compartment of an alveoli, the interstitium, and a capillary. If we apply 30 of pressure and the pleural pressure is 10, the PIP of 10, and the patient is totally passive, the transpulmonary pressure in that case is 20. So we can say that this is protective, okay? The transvascular pressure, which is the capillary minus the pleural pressure here, in that case is 2. So, I can, figure out that the ventilation here is protective. However, if on top of this mechanical breath, there is an spontaneous breath, the mechanical breath, it's 30. So there are two pressures acting in opposite way. Then the pleural pressure, if the patient inspires hard, strong, is minus 20. The transpulmonary pressure is 60, but the transvascular pressure is also very high because this negative intrathoracic pressure increases the venous return. And then, the transvascular pressure in that case is 28. In that conditions, there is interstitial fluid in this interstitial space, and also it can cause edema, shear stress here, and also lung injury. Therefore, looking at when we are at the bedside and we see a patient that is poorly interacting with the ventilator, we need to think on the vascular consequences of that. Again, if we look at in the consequences, and the patient has air hunger because the flow is, in that case, insufficient, or maybe because we are not good setting, the inspiratory time of the ventilator according to the inspiratory time of the patient, air hunger, dyspnea may appear, and we should not forget that the air hunger projects to the insula in the limbic system, and the insula is the site of the dyspnea, hunger and thirst. Afference of the chemoreceptors goes there. A stretch receptors of the lung project to the insula is the seat of emotions, and it has a large role in memory. Maybe this can have I mean, an influence on the cognitive alterations of the patients, not, I mean, in the ICU, but in the post-ICU period. But this is still a matter of research. Dyspnea is important, of course, because in this very interesting paper, Smith and co-workers found that half of the patients mechanically ventilated in the ICU report dyspnea. It's very difficult to assess dyspnea in a mechanically ventilated patients. Dyspnea, I mean, is not associated with age, severity, or the indication for mechanical ventilation, but dyspnea is significantly associated with anxiety and assist control ventilation. And interestingly, when they decrease dyspnea, increase successful extubation. So the cause of dyspnea sometimes is unknown, but we first must examine, I mean, in that case, how we have set up the ventilator, and the ventilator must be set up according to the respiratory center of the patient and according to the metabolism of the patient. So the next part, are asynchronies present or frequent in the ICU? This is a work that we did with a specific software. And during all the days, 50 patients in the ICU, all the days from the day 0 intubation to the extubation, the asynchrony index was present. Asynchrony index was based in the combination of 4, in that case, asynchronies: short cycling, prolonged cycling, ineffective efforts, and double cycling. And this was unpredictable, very difficult to predict. Here are 4 examples of a patient that, I mean, asynchronous in the majority appear in the last period of the mechanical ventilation. Almost no significant asynchrony throughout mechanical ventilation. This patient in 7 days presented lots of asynchronies, again, during all the time of mechanical ventilation, and this patient in the beginning. So asynchronies, I mean, can appear all over. And now I'm showing you funny pictures, okay? This is during the COVID, for reasons that you can easily, I mean, guess, in the newspaper, there were pictures showing patients in the ICU. And I found this one that showed the ventilator. You see what's going on here? This is a short cycling, okay? This is a patient triggers the ventilator, but clearly the inspiratory time of the patient is longer than the ventilator inspiratory time. In that case, this is probably, I mean, pressure support. So, and then this type of asynchrony just appears when, I mean, the ventilator enters in expiration, the patient is still inspiring. This can cause dyspnea, maybe air hunger. Is this deleterious? Honestly, I don't know, but this is an asynchrony. And then a Welsh newspaper, when they presented that case to show that the patients are in prone position. But the interesting thing here is the ventilator again, because if we look at here, this is a reverse triggering. You see, this is pressure, the patient is not triggering the ventilator, and you will see, you know, a reverse triggering in late inspiration. So asynchronies occur quite often, and this is in the media, in the newspapers. Then let's talk a little bit in the effect of asynchronies on outcome. In the paper I commented before, we just published in a table some data on ICU mortality. This paper was not designed, I mean, to study the effect of asynchronies and outcome, but we found that when asynchronies are higher than, asynchrony index is higher than 10%, it seems that there is more ICU mortality or hospital mortality. But honestly, we cannot say that this is true because the paper was not designed. We cannot say that asynchronies are associated with severity, or simply that asynchronies can, in that case, alter outcome. If we go back to the paper of the interesting paper of Brochard, one of the first papers dealing with asynchronies, an asynchrony index higher than 10% was associated with more days on mechanical ventilation, more percentage of tracheostomy, and more than 7 days under mechanical, so more prolonged mechanical ventilation, but not associated in that case with mortality. Probably because we need to think not in the asynchrony index as a general, but on how this asynchrony occurs. But based on that paper, we were interested in our group showing the effect of tracheostomy on asynchronies. And in a paper that just has been published, several months ago, we just monitor, look at all the waveforms before and after the tracheostomy, and you will see here the tracheostomy, maybe. It adds comfort to the patient. It might decrease in some patients' work of breathing, but has no effect in that case on asynchronous. And this makes sense because sometimes, or most of the times, if the patient has asynchronous, is the consequence of the people who set up the ventilators. So, keep going with the effect of asynchronous in mortality. We work with some mathematicians and highly specialized, statisticians, where they propose use a Bayesian model. Let's say to use, these statistical models are the ones that must be used to analyze longitudinal data. So we analyze the effect of SOFA on mortality in these 139 patients, and also asynchrony. So we just analyze using the software all the asynchronous. SOFA discriminate perfectly the patients who, the alive patients, the patients who die. But asynchronous, this was really interesting. It seems that asynchronous are associated a little bit with survival in the ICU. That was a little bit shocking, but looking specifically into representative patients, this is the patients who died. This is SOFA, day 1, 2, 3, and 4. And SOFA increases, day 3, SOFA increases day 4, and asynchronous stays low. Why stays low? Sedation, because the patient was fully passive, maybe paralysis, we don't know. Alive, the SOFA decreases at day 4, and progressively, as the patient improves, asynchronous increase. Why? Because when the patients, in the transition from control to spontaneous breathing, the transition from sedation, in that case, from full consciousness, the patient starts to interact with the ventilator. And maybe interacting with the ventilator is not wrong per se, it's how, again, the patient interacts. Maybe we can say permissive asynchronous in the patients under mechanical ventilation. So the group of Georgopoulos published, I think, a very, very important paper in 2017, because they say asynchrony index maybe is not important, but it's clusters of asynchrony, so how they happen, which is the key point. So they define a cluster as a 3-minute period with more than 30, in that case, ineffective efforts. And what they found is that asynchrony index, was not associated with mortality, 0.08, but clusters, yes, and clusters in terms of power and duration. In other words, if the clusters last for a long time and has a huge power, which is many asynchronous, this is deleterious. We also look at, with the Brazilian colleagues, clusters in that case of double cycling and breath stacking. And in a group of 100 patients using, specifically the software, we found that if the clusters had low duration, less than 12 hours, compare in that case with high duration, more than 12 hours, high duration was associated, as you will see here, with less survival. And this was when was adjusted by the duration of mechanical ventilation, and in that case of severity. Again, we have evidence here that is asynchronous probably are associated with the normal behavior of a patient breathing in the ventilator, but when this turns in a cluster, and in a cluster with high duration and higher power, this has an effect on outcome. Again, this is a paper that now we are submitted for publication. In another cohort of patients, we measure cluster, and we reproduce the results of Georgopoulos, we reproduce the results of the Brazilian colleague, and then if I show you a cluster here, this cluster appears in the middle of a patient ventilator interaction in a different forms up to a point where a cluster appears. If one cluster appears, by per se, is not dangerous, but is dangerous when it has a determinate duration and power. So again, what's important here is not the software to measure this. What's important is to be at the bedside and pay attention of how the patients are interacting with the ventilators. Just to start, not finishing, but the last part, COVID patients. All of us have been threatened by the COVID pandemic, by silent. Now we understand what is silent hypoxemia. When this progresses, increases dead space and shunt, and when that happens, this patient present increase in drive, increase in effort, increase in rate, and increase in dyspnea. And in particular, we have discovered a different percentage of mortality all over the world, and also a different percentage of, use of sedation and paralysis, which is still we have not answered why we have this dispersion of this. And it is interesting because when the Tonelli and colleagues compare, in that case, the inspiratory effort in patients before invasive mechanical ventilation, when they are in non-invasive ventilation, in a matched control study of 2 cohorts with this COVID, patients with COVID and patients without COVID, so just with hypoxemic respiratory failure, they found that the inspiratory effort was much higher in non-COVID patients. Why that? Probably because if we look at here at the mechanical power and the dynamic compliance, this patient still do not have an impairment, just have, let's say, silent, in that case, hypoxemia. This is interesting because when we turn to look at the respiratory effort in COVID patients when they are in invasive mechanical ventilation, they found this is the normal values of work of breathing in joules per liter, and here in joules per minute, we found that in this cohort, they report that the work of breathing here is high. And interestingly, this can be explained by this, by this physiologic review paper. Initially, if there is a mild lung injury here, probably the inspiratory effort, is as shown before, is let's say normal. As the patient progresses and when there is diffuse alveolar damage, maybe there is more the inspiratory effort increases. The key point here is that what causes this? The disease, or because the inspiratory effort increases and also adds some lung injury. And here is the fibroproliferative stage. The authors present that if we have low distress with low inspiratory effort, maybe the patient recover, but if we have high distress with a high inspiratory effort, maybe this evolve in that case to, a more injurious lung with more alveolar, consolidation and more fibrosis. But maybe what conditions the inspiratory effort is the disease, not the contrary, or maybe both. So there are unanswered questions here. But importantly, when these authors analyze the PO1 and the amplitude of the muscular pressures in patients with COVID-19, they found that the patients with a PO1 higher than 3.5 and the pressure less than -10, the ones that had that were the ones that there was a relapse, so they were reconnected to mechanical ventilation. They could not be liberated of the mechanical ventilation. So it seems that in COVID patients, there is a problem in that case with the high respiratory drive and high amplitude in that case of the muscular pressure. Now, having said that, we don't know if this happens because the disease, because there is an effect, a neurotropism of the virus in the respiratory center plus the disease in the lung, or simply because the shortage of manpower or whatever, we paralyzed more in that case the patient. However, one of the proposed treatments in that conditions could be sedation. And I would like to talk a little bit about sedation and asynchronies because it is important. There is a belief that if the patient has a poor patient ventilator interaction, if we sedate the patient is just fine. And what happens is that the patient looks more calm, but the asynchronies are there or even they have increased. This is a paper of Marjorie DeWick when the patient presented inspiratory efforts, they increase sedation. So there is increase in sedation, and you will see here how the ineffective trigger index in that case increase. And this is very well represented here. The effect of sedation is decrease the output of the respiratory center. So electrical activity, of the diaphragm decreases, but not the rate. That's why, these small ineffective efforts cannot trigger the ventilator. This is nicely shown in this light and deep sedation in pressure support. When it was switched from pressure support to NAVA, then obviously each electrical activity of the diaphragm was followed in that case by a mechanical breath, because this is the principles of how NAVA work. Then again, sedation, per se, do not relieve the patient to have asynchronies. Again, we were a little bit worried about that problem, and then we studied the effects of sedation plus opioids on asynchronies in patients under mechanical ventilation. So we studied 79 patients all the time in mechanical ventilation, and these are the results. We used a mathematical model of linear mixed effects, and we found that when there is no drugs, the patient has asynchronies, which progressively decrease when the patient has sedative plus opioids. Okay, that's fine. And this is how ineffective efforts and double cycling behaves. When we analyze the level of consciousness, this is the sedation agitation scale, we found the maximum level when there is no drugs, because the patient in that case was awake. But when the patient here has, as you will see, sedatives, the sedation agitation scale, as you will see here, decreases, but not with opioids. With opioids, the level of consciousness was more or less the same and was much lower, as you will see here, with sedative plus opioids, because as you see here in the sofa, these patients were more severe. But this is the interesting plot. We plot a synchrony index as a function of the midazolam dose equivalence in sedatives only. Therefore, when there is, increased sedation has a mild but non-significant effect on the asynchrony index. When sedation was increased with opioids, asynchrony index increased. However, when we look at asynchrony index as a function of the morphine dose equivalence, interestingly, asynchrony index with opioids alone or with sedative plus opioids, increasing opioids, the asynchrony index in that case decreased. So sedatives alone or combined with opioids do not result in better patient ventilator interaction than opioids alone. Opioid dose alone or with sedatives was associated with lower asynchrony index without depressing the consciousness. And this is very important because with opioids only the level of consciousness was the same as compared with the episodes of no drugs. And then it is obliged to go to the paper of Strom, because in this paper is a randomized trial on sedation versus no sedation in ICU patients, and no sedation has better outcome compared in that case with only opioids. It is interesting because sedation increases the hospital and the intensive care length of stay, increases in that case the mortality, and the morphine doses in the sedation and no sedation groups was exactly the same. Perhaps we need again to look at if we need to sedate the patients in as much as we do in the ICU. And the paper of the Ventilator group, it shows again, and this is published just a week ago, that the PO1 of the patient is exactly, I mean, not significantly different at the different levels of sedation measured with the RASS scale. And when they, let's say, respiratory drive can be low, moderate, or high across the range of routinely targeted sedation depth. And when they look at the correlation, the coefficient between when the PO1 increases with lighter sedation, on the PO1 increases with deeper sedation, there is absolutely no correlation, concluding that the sedation depth is not a reliable marker of respiratory drive during critical illness. So when we look at sedation, think again on physiology. In the COVID pandemic, there were some case reports showing not only breath stacking and double cycling, but a triple, I mean, cycling and, you know, a triple, as you can see here, tidal volume. And the people say these patients we could not satisfy air hunger, generate an excessive effort, and culminate in multiple triggerants that can cause volume trauma and barotrauma. This is caused by the disease, by the shortage of manpower, and simply because we do not understand the disease. I mean, I don't know, but I mean, it's a phenomenon that is there. And to conclude, I would like to show you some examples. These are patients from my ICU. The flow is 59, it's accelerated flow. The peak is, well, as I said, 59. And this is a patient that it triggers. Each breath triggers, but there is a huge inspiratory effort. You see how, you know, the pressure, I mean, it decreases the pressure because there is a strong inspiratory effort. So this is a patient in the ICU. Since we are collecting all the waveforms, I mean, we just, I mean, look at that. This is another patient, but the difference here, the patient triggers the ventilator, but the patient is not triggering the ventilator. So here this is a reverse triggering. This is a time cycled breath, and I mean, the inflation triggers an inspiratory effort of the patients. I'll look at the decrease in that case in the pressure. I mean, this corresponds to a huge, in that case, I mean, swing of negative pressure, and a huge, in that case, transpulmonary pressure. But look the difference. This is a breath triggered by the patient, and you will see the difference between this pressure swing and this pressure swing. So we need, in that case, to match the respiratory rate of the patient, in that case, in order to have all the breath be patient trigger in the ventilator, and then try to adjust this inspiratory effort by playing with the P, perhaps increasing the tidal volume. So the physiologic judgment, it's very, very important. Here, another patient, this is in volume control. The flow is 45, probably is not sufficient. And again, the pressure swing goes below PEEP, which is a characteristic feature of this strong inspiratory effort. So the problems of what I shown to you is a strong effort, large transpulmonary pressure, pendulum deformation, and probably, I mean, patient-induced, in that case, self-inflicted lung injury. My last slide before conclusions. These are the clusters. These you cannot see here, clusters of reverse triggering and breath stacking. And I've seen I have not seen ever this cluster. This is a cluster of duration hours, with an incredible power. This durates almost 10 hours with all this power. This is because, I mean, we need to pay more attention to the ventilated patients, of course, for sure. However, if we have 50 patients under mechanical ventilation, shortage of manpower or whatever, maybe we need some tools that tell us that this is going on. That's why, I mean, we can go there and interact immediately, at least in those patients that they present with these, I mean, clusters with high power and high duration that for sure, unfortunately, this can affect outcome. To conclude, asynchronies are present during all periods of mechanical ventilation and in all modes. Asynchronies in general are probably not related with a bad outcome, and this is controversial. I mean, this is provocative. However, high cumulative duration of clusters of asynchronies, double trigger, or ineffective efforts are associated with poor prognosis, shorter survival, less ventilator-free days, longer mechanical ventilation, and longer ICU stay. Sedation does not control respiratory drive, so be careful in the belief that increasing sedation, the patient is more calm and has much better patient interaction. Connectivity, interoperativity, and artificial intelligence is needed to better understand patient-ventilator interaction throughout ICU stay. But, and this is the most important conclusion, do not forget that ventilator management demands greater understanding of physiological principles. As Martin Tobin said, always one of the most difficult things in the ICU is to understand how a patient interacts with a ventilator, with all this crosstalk between organs, the lung, the brain, and the cardiocirculatory. Thank you very much.
Luis, that was, as always expected, wonderful. I really enjoyed that. I think understanding the clusters, you know, we talk about synchrony, but understanding how the clusters have a big impact in COVID. I've got two questions. And this is about ventilators or ventilation, how we use them. So the first thing is, in the COVID patient, where people are still probably using volume control ventilation, do you think a mode such as, and it's an old mode, but like PRVC, still targeting volume, but using the, you know, like with a pressure controlled algorithm, has an advantage, even though we both know it's got negative impacts too because of the mean pressure and so on? Does it help address that? What's your thoughts?
Okay, that's a very interesting question. I am not sure. I mean, there are no investigation that the pressure-regulated volume control compared with volume control. In that case, which one is better? But I mean, people uses volume control because they understand more mechanical ventilation. And in case of a high inspiratory effort, if we use pressure-regulated volume control, I mean, we are pressurizing. I mean, because the variable that the variable that we regulate in the ventilator is pressure. So we have two pressures going in the opposite side. So the ergo pressure is high. At the time, there is a huge inspiratory effort. That means a large, in that case, transpulmonary pressure that maybe can cause injury. Whereas if the patient is in volume control, when we set volume, and then the pressure, I mean, the patient may suffer in that case from anxiety or air hunger or dyspnea or whatever. But in transpulmonary or transvascular pressure, maybe the effects are less. In fact, when there is an investigation that compares lung injury, in that case, in volume control at different PEEP levels and pressure control, and they found that volume control in terms of lung injury is more beneficial compared in that case with pressure control. So this is based on experimental issues, no? But I prefer myself, or I should say, because now I am fully dedicated to research, but always in the ICU, you know, I prefer volume control. Why that? Because then I have absolute control. I can understand physiology. Immediately, I can measure a bunch of different mechanic parameters, resistance, compliance, driving pressure, or so, and I have a much more precise figure of what's going on in that case in the lung. I have nothing against pressure control. Okay, I like also pressure control, but in pressure control monitoring, well, we need perhaps a more tight monitoring. And of course, if the patient has, I mean, a strong inspiratory effort, I would prefer volume control and then to see what can I do, or switching to pressure support. But this also can be dangerous, because sometimes if there is this strong effort, they switch to pressure support, and then, with a small pressure support, since the effort is so high, tidal volume is 1 liter. And this is, the announcement of an increase in the lung injury. So think always in physiology at the bedside, and avoid situation of high transpulmonary pressure and high driving pressure.
I suppose old modes like SIMV, volume controlled SIMV, where people select, say, tidal volume of 400 mils and say pressure support of 10 or 15. But in my opinion, this is a terrible way to ventilate patients, because it's this whole mixture of control and then lots of variation of volume and so on, that must in turn create more anxiety, right? More sedation, more, because you fight the ventilator continuously.
Yeah, I am classical, but I like the three classical modes: volume control, pressure control, and pressure support. Okay, then we can talk on proportional modes. Okay, but dual or combined modes, I think, are very, very difficult to understand. And at the bedside, to understand, people, professionals, must have a profound knowledge of physiology, looking at a patient who is in the SIMV pressure control plus pressure support in spontaneous breaths, or in some volume support. You know what I mean? This is quite complex to understand. So I prefer to stay in the classical modes. They are the more studied. And on top of that, there are no studies saying that those modes are superior to the classical ones.
One last quick question that I don't want to hold this up because there's 3 questions waiting. But what's your thoughts too on, for example, some of the algorithms, like for example on Bella Vista, which, the automation component, for example, rise time and synchrony. Do you think these have a place in dealing with asynchronous issues?
Okay, it's algorithms that react when there is, for example, it detects that the rise time should be higher and increases the rise time, or it improves the cycling off, for example. The cycling off from inspiration to expiration in modes such as, in that case, pressure support. It's they may have an utility at the bedside, but sometimes it is absolutely necessary to understand the different causes the patient presents that asynchrony. Okay, for example, if the patient increases the air hunger and the algorithm increases flow, maybe we are delaying some actions to the patient because the patient anticipates something that is going on related to the clinical conditions. I like more algorithms that tell to the clinician that something is going wrong, okay? And then the clinician, either having automatic decision algorithms in the ventilator, the clinician may decide how, in that case, to use that. And maybe then expert systems in that case are useful, because I decide that I correct the cause of that, but then I improve further the condition of the patient with the ventilator. So yes. I'm doing precisely, this is one of my line of research doing that. But I strongly believe that, the knowledge of the physiology is essential. And all these artificial intelligence or expert systems will help us to much better understand not what's going on when we are there, what has happened when we are not there, which may be the consequences of we are looking now.
Yeah. So Lluis, at the bottom of your screen, you can see the Q&A function, and there is 3 questions there. Would you like to answer those?
I have. Oh, can you emphasize on the way how to resolve reverse triggering and double triggering? Okay. So reverse triggering. So reverse triggering, as I explained during my talk, you need, in that case, to decrease, respiratory rate and see whether the patient, or the ventilator catches, in that case, the inspiratory effort of the patient. And there is one maneuver which is essential. You need to do an expiratory occlusion to see whether the patient is doing, during the occlusion, inspiratory efforts, because then there are two patterns that coincide, or there is no effort. That means that each ventilator breath triggers, in that case, a patient breath. So in these two conditions, the treatment might be different. So if reverse triggering is caused by a huge, causes and a huge inspiratory effort, then we must decide how dangerous is that. In other words, if this huge inspiratory effort, we cannot relieve that by playing with the respiratory rate, perhaps increasing a little bit tidal volume, okay? Because tidal volume could be 6 or 7 or 8. This, it must be, judged according to the driving pressure. But the patient keeps going with this inspiratory effort, maybe then is the time to use some drugs, some paralytics at the bedside. But the paralytic must be the last option. So double triggering. Double triggering is just because the inspiratory time of the patient, in that case, is longer than the inspiratory time of the machine. In that condition, you need to play with the ventilator to match both inspiratory times. And this, in that case, can be done essentially, if the inspiratory effort is not strong, by switching, in that case, to the pressure support. You could, sometimes it is recommended to increase the inspiratory time by increasing the pause, but we are not breathing with the pause regularly. So if you increase the pause, you generate, in that case, an afferent to the respiratory center, and maybe then you can increase the respiratory rate, causing ineffective effort. So, then one of my old professors said that the best way, to solve asynchronous at the bedside, the best tool is a chair. You know why? Because it takes time. And then if you are not sitting in a chair, you get tired, stand up at the bedside. So, well, I think I already answered your question here. So the next question. On the last two cases from the ICU, your work, why was the patient not switching to SIMB more instead of TAL? Okay, excellent question. I don't know. Probably because the answer is simple. I don't know if with SIMB the situation could be better, but simply because I presented that patient because we are collecting waveforms, apart from the clinicians. So when that happened, nobody, alarms, or nobody was there to react in front of this asynchrony. And is my ICU a bad ICU? No, it's not a bad ICU. But I am sure that many ICUs in the world during different periods, if there is not, nurses are not trained, or there are not therapists, or there are no doctors there, many of these situations get unnoticed. That's why, I presented that case. So next question. Pressure regulated volume control would be contraindicated to the patient changing demands, in my opinion. The pressures would continually vary, and if the PT the patient overbreathes the bend, the pressure will keep dropping on the subsequent breath until reaching above PIP said. Yeah, you are right. You are right. If the patients in that case keep pulling, and then it could be that the pressure goes down to 5 and the tidal volume is 600, and then the patient has a strong effort and the ventilator is not increasing in pressure. So you are right. In my experience working COVID ICU, pressure control works better for those patients that are either assist control or volume control or pressure regulated volume control, being a little more favorable than IVC. Okay, I agree. I like pressure control as well, but remember that when the amplitude of the muscular pressure is very high, you should pay attention in that case to the transpulmonary pressure, because then there are two two pumps acting in a different way, and this may increase injury. So the next question. Can you emphasize on the way how to resolve reverse triggering and double triggering? Well, this is the same question as I answered before. Are these studies being conducted on a stress index versus severe COVID patients on mechanical ventilation? Well, a stress index. Okay. I think you are referring a stress index in that case as the variation as the exponential variation in pressure when the patient is passive breathing. So it's completely adapted to the mechanical ventilator in conditions of the square flow. If you have at the bedside, I mean, this indication, this tells you in that case if the patient is overstretching the lungs, over-distending, or if the patient has recruitment at the end of inspiration. In each case, the treatment is different. With that tidal volume that metabolically is correct for the patient, if you have recruitment, let's say the pressure decreases for the same linear increase in volume, then you need to increase PEEP. But if you have that there is with low tidal volume over distensions, let's say the pressure increases fast at the same linear increase in tidal volume, this means over distension, and in that case, you need to judge whether there is excessive tidal volume or excessive PEEP. And then when you have finished with your adjustments, look at again the stress index, but also look at, in that case, in the driving pressure, and then you will have a physiological answer of what you have done in the ventilator.
So
no more questions.
That's it, Lluis. That was superb. Again, thank you for your time. I'd like to thank everybody for attending. I'm sure everybody's really enjoyed this. It's good to hear the master teach us continuously on something that we have to be aware at the bedside. Lluis, again, always a pleasure to talk to you, and yeah, thanks again so much. Really, really good, and yeah, good job.
Thank you, Grim, for this nice invitation to talk, and thank you the audience for lots of questions, but do not forget physiology. Physiology is the must in the ICU. So thank you very much.
Thank you, everybody.
Bye bye.